Hey, Musendo, can you hear me?
Yes, I can hear you.
Oh, good. How you doing?
I'm fine. And you? How are you?
Good. I just got back from Mexico.
Oh, we're in Mexico now.
Right now I'm in Miami,
Okay.
but I went to Mexico to meet with Big Pharma in Mexico City.
Okay.
I'm trying to televise conferences for their company. It's a
Ah,
pharma company, and they have a lot of doctors working with them, and they want to set up channels of Zoom
okay.
with their physicians in all areas of medicine, not just neurosurgery.
Okay.
But we'll see. I don't know if we'll see how it goes. But as you know, it's a very good platform for communication.
Yeah, very good. It's
And you're
okay.
using a smartphone, right?
Yeah, I am using in smartphone. I'm using in computer, but usually I use it in smartphone. It's very
Oh, okay.
easy. Everywhere.
Yeah, it's effective. Just the smartphone is very effective.
Yes.
Because really what you want is what the person's mind says. It's nice to have the picture too. But well,
Yes.
so how's it going with you in Mozambique?
Now I'm in Vacas. I'm with my wife and my children in Ampulas, another city of Mozambique.
Oh, another part of Mozambique.
Yes.
Okay, it's not where you work.
No. It's not where I'm working now. It's where I live my family.
Oh, okay, very good. Okay, I'll be back.
Okay, thank you.
Okay. Buongiorno. Let me take your microphone off. Andres.
Hello, John.
Hey, how you been?
Fine, fine. How are you?
Good, good. Are you at home or in the hospital?
I'm in my parents' house because I'm just in the middle of the moving, as you can see from all the luggages.
Oh yeah, oh yeah.
Yeah.
Well, your reception, your video is very good, and your connection is very good.
Yes, yes. Because it's my parents.
Oh, but yeah, when the internet connection is good, the camera, it's very distinct, good resolution,
Yeah, exactly.
and the voice is really good. That's why I tell people I just got back from Mexico, and the internet connections there aren't great. But everybody has a smartphone. Um, so if people can just get to a decent internet connection, you can do a very effective video conference chat with a smartphone.
Where are you in Mexico?
No, I was in Mexico City
Okay.
for a couple of days talking to a big company that they do 70 conferences a month.
Oh.
A month.
My God.
Yeah, but the problem in Mexico is the internet connections are limited to the bigger cities.
Yes.
Yeah, and once you get outside the bigger cities, the smaller cities don't have very good. So we're gonna.
We have the same problem here, but Italy is small, so nowadays almost everyone has a decent connection. But we
Yeah,
had that problem like 10 years ago.
right. It's the same. It's probably more in Mexico City,
Yeah,
Mexico, the country, than most other countries. But we'll try it because they have a lot of conferences, but hopefully I'll be able to televise them to support myself,
yes, yes, yes.
and then to continue to grow, get program, just get a team together, really.
Mhm.
But yeah, let me check with Ipe here. It's because I just got back. We didn't really promote this very much. So how is your practice going?
Good. Now now I've been working in my latest hospital for the last 2-3 weeks, but I'm traveling and I have 1 hour to get there and 1 hour to get back. So I'm just doing crazy hours. I'm doing like 6:30 in the morning. I'm leaving and I'm going back by 10 p.m. So
Wow.
now I've got a house. I got
Oh,
it. So
it's an hour away from your hospital.
yeah.
By drive or train?
Yeah, by drive because I have crazy hours, so I cannot trust on
The train, yeah.
Italian rail stations.
Oh, yeah.
No.
Never on time, right?
No, never, hardly ever.
Well, it's the same here, and I don't depend on the bus because I take the bus. I can't depend on it.
Uh, no. And now I'm moving. I'm just doing latest stuff. I'm taking clothes and everything. So
Oh, you used to live at home at the house there?
I no now I've been for the last 3 weeks I've been to my parents' house,
Oh,
and
okay.
and now I'm moving to a house on rent
Right.
that I got in that city because it's too different. They are close, but it's still 1 hour of driving every day. So
Yeah. Wow.
too much.
Yeah. Yeah.
But
You listen to educational tapes on the way?
yeah, exactly. No, and everything is fine. In last year of residency,
Oh, good. Do you know where you're going to practice?
I think there in this new hospital because I moved there because I wanted to. I asked my university and they allowed me. So usually in Italy, that's what we do because once you finish your residency, it's just you're on your own and you have to find yourself a job.
Oh,
So
okay.
usually for the last year, you try to spend time in the place that you want to be hired.
Oh, okay.
You want to be
Yeah.
hired.
Right. Right. So,
So
but
common practice.
did you buy the house or are you just renting?
No, I only rented it.
Oh,
I'm poor.
yeah. Yeah. That's a commitment. When you buy a house, you commit
Yeah,
yourself.
exactly.
So,
No, but if I get hired there, there's a good chance that I will, I'll make a loan, yes,
right.
loan,
Right.
uh, to buy a house, but not until I sign a contract.
Right.
You know,
Right.
it's
And
the thing.
plus, you might go somewhere else for a fellowship or something else, right? Or,
Yeah, I know.
I-
I don't know where I will go. I mean, in these years, I've done so many different things. So I've started doing vascular, and then I did some endovascular, and then I went to IPS and I've done some skull base, and
Mhm.
now they're making me put screws everywhere, so a lot of spine here because they needed someone with for the spine. So you never
Oh,
know,
okay.
never know.
So the job that you're trying to get, will you do general neurosurgery or spine or both?
Actually, we are all general neurosurgeons, but you tend to specialize later in your career.
Oh,
So
later.
I've done everything in my residency. I'm very lucky to I have been able to do mostly everything, and many people cannot do that.
Right.
So I'm not an expert, of course, but
Right.
I've seen a lot of different things, so I'm prepared for everything that may come.
Oh, good. So you haven't determined what subspecialty
No,
you may go into.
my chief asked me to do vascular because he needs two people, and there's another girl that have been. I don't know if you know him. It's called Shu Bin. It's the Chinese guy. He does the most bypasses per year.
Don't know. How do you spell that? Chubin.
No,
Shubin?
Xubin.
I don't know him. I haven't met him.
Uh,
No.
but he has this huge facility, and she's been there for like a year, I think, and she's very good with the bypasses.
Oh, okay.
But she's very young and she's very very good, but she's focused only on that. And for example, she cannot do spine, she cannot do many things. So he told me to be the other vascular guy,
Yeah.
and he's trying to put me with the radiologist for the endovascular part as well. And he asked me to perform the spine, but the difficult one, not the posterior approaches, but he wants me to do an anterolateral approaches to the spine,
Oh,
which
okay. You know, it seems that neurosurgeons either like spine or don't like spine.
I like it. Actually, in it, I don't know if it's true in every country, but in my country, since we are not very big, we are not dense populated like other countries.
Yeah.
Most, I think 2/3 of the things you do, especially when you're young, is spine, simple spine, hernias, spondylolisthesis, and stuff like that. And there are many people that really cannot do that because they focused on the cranial things,
Right.
which is something I think it's not very very good in Italy. Not
Okay.
in every
Okay.
country.
Okay.
So it's good for me. I know how to do a discectomy. I know how to do fixation. I've learned the percutaneous approaches, vertebroplasty. I can do most of the things by myself, or with little supervision. So it's good. I don't know what will be, but I'm
Right.
trying to.
You know, when I see the older neurosurgeons, the very big ones, they
Huh?
all seem to have spent some time in Japan.
Yeah,
Yeah,
because Japan was
is that considered the center of the best place to do a fellowship in vascular neurosurgery?
yeah,
Yeah.
yeah,
Yeah.
exactly. The problem is there are two problems. Japanese are crazy.
Yeah. Really?
No, there's a good friend of mine that he's been with Yoko Kato for the last, I think, 3 months. He
Oh, okay.
left. He left when I left for IPES,
Okay.
and he's been there only for observership. He did not perform anything, but and they and everyone who's been there tells me that they work like crazy. They had like this mm, time schedule so full, and when they don't operate, they draw the operations and everything, and I think it's not very healthy.
Oh, really?
Yeah,
Wow. Yeah.
you
Well,
have a life as well.
I think I may have met him. What's his name?
Riccardo Stanzani, you met him,
Yeah.
of
Oh, yeah.
course.
Yeah. He did a couple of presentations.
Yeah, I know. I actually couldn't. I haven't been able to see them because I think I was traveling.
Okay.
But I told him that now there's a little bit of an Italian team in
Oh.
Neurosurgery TV.
Oh, yeah. 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 But Ike did a fellowship there. Sufianov did a fellowship there. Yuha, I think he did a fellowship there. Oh, when early in their careers, it seems.
Yeah, because they were the ones that were pioneering the vascular and skull base as well approaches. They were actually they are good as nowadays too, but the problem with vascular surgery is that it's going to die.
Oh, really?
It's going to die, and not so slowly. That's why it's
Yeah.
it's
That's
difficult.
good.
It's difficult. I think I told I this thing many times, and he agrees with me. Despite his aggressiveness with approaches, and despite he's right about five 5/6 of the world are cannot afford devices and everything, but that's something that is going to change very quickly, I think,
You
because
think so?
these devices, they cost really a lot in the first
When you say
five. Huh?
devices, what exactly do you mean? What devices?
Like flow diverter, like coils, like everything. And,
They're expensive
uh,
to buy.
they are expensive, but only for the first 5 to 10 years.
Right.
After that, the prices drops, and I think, for example, flow diverter for the cavernous aneurysms are superior to surgery. That's
Right.
a fact.
Right.
Even I, with his experience, so we were speaking about this. With his experience, that's a steep learning curve, and it's very
Yeah.
very. I I thought I understood some things he did with the clinoid, but
Okay.
actually I didn't I understood that I hadn't understood when I went there and I saw him in first person. And it's very, very complicated. It's doable, but it's very, very complicated.
Oh, okay.
And you know, I put flow diverters, I put coils after 6 months in with a radiologist. It's totally different. It's totally different, and
Oh,
the
okay.
results are very.
Well, I'm sorry. I'm trying to. I think I don't know where Ipe is. Hello.
I'll text him.
Yeah. Yeah. I hope he's not mad at me because I thought he wanted the title of the talk to be cisternostomy. A storm is brewing. Uh, oh man.
Uh, uh, let's see.
Musendo, can you hear me? Musendo.
Yes, yes.
Yeah,
I can hear you.
I want you to meet Andrea Gerosa. He's an Italian neurosurgical resident, and he's at home now.
Yes.
Yes.
Musendo is from Mozambique.
Okay.
Yes.
Nice to meet you.
Yeah. Oh, even for me, nice to meet you.
He's also using a smartphone, and he comes to all these. He's a very enthusiastic student.
You are a medical student.
No, he's a resident.
Okay.
Yes.
Okay, here's Sugar. I don't know if you met Sugar, Andrea. He was in Nepal for a while.
Yes.
Were you with Sugar? Sugar?
No.
Okay.
I haven't met him, but I've met Edmundo, who is Sugar's friend, I think.
Yeah, Sugar's in Peru. Cusco. Hello, Sugar.
Hi, John. How are you?
Good. How you doing? I'd like you to meet Andrea Gerosa, a neurosurgical resident from Italy.
Hi, Andrea. How are you?
He was also with IPE.
Yeah. I think I know that you have been in Nepal with Professor Chiren.
Yeah. I've met. I was with Edmundo the last. When he came, he's still there, I think, and he told me that you advised him to go to Nepal.
I think one thing is important to see at first sight that what all this cysternostomy is about, because when you try to understand, sometimes it's kind of difficult, and it's something that maybe you should or you cannot believe that it's working. But once you see it and you see the results, you see how the brain laxes after cysternostomy, I think that changed your mind. And also being with Professor Ipe, I think is a mind-changing
procedure.
Yes.
Yeah. I agree. And actually, I managed to do a couple of cysternostomy while I was there. So that is one of the reason I went there, to be able to perform it by myself in Italy, because since it's not something very commonly done and accepted, you don't want to screw up.
Well, I'm sure you know Corrado Iacorini, right?
Yes. I'm working in the same hospital.
Okay, he's not a big believer in cysternostomy, right?
No, actually, he do believes. He do.
Oh,
Uh,
okay. I wasn't sure because
but
they seem to have discussions.
yeah, yeah. The thing is that Franco is a very scientific guy, and he's a disciple of Franco Servadei, the president of WFNS, and they are very they they tend to believe only in the studies, which is something very good. It's something that we need, but I don't think he antagonizes hype because of only because he wants to, the evidences of cystonostomy is working, and I think he do believe that
Okay.
works, but he wants the proofs for everyone. So
Right. Right. Okay. Very okay. Yeah. Yeah. I remember working with people like that. Very strict with data. I may have had something come up. I don't know. Did he answer your text, Andrea? Did you?
sorry,
Can you text IPE?
I texted him, but he hasn't seen
Yeah.
the
Oh, okay. Maybe something came up. I don't know. Let me try his. I'll be back. I'm gonna try some other stuff. Hold on. June. Sugar, are you there? I wrote right
Yeah.
again. Sugar, I just got back a couple of days. I just got back from Mexico City. Sí,
How was it?
sí, yo fui para visitar una compañía de drogas allá. Una farmacia. No, realmente, no ese tipo de drogas. Una farmacia grande. Una compañía.
Okay, okay.
Oh, Ipe está aquí. Okay. Hey, Ipe. Good, I'm glad he came. Hey, Ipe.
Hey, can you see me?
Yeah, we can hear you.
Can you see me?
Yes,
Yeah, we
excellent.
see
Good
you.
to see you.
We just finished the completely crazy and we had a where it really bled before we opened, and it was, and then we had completely tense brain. Even after taking out the EVD, we had the brain like stone. So we went in, we put the first clip, and then it ruptured, and then it was fun for some time. Then I had to clip off the for some time. And after that, we took off the clip of the A1, the aneurysm ruptured again. And it was a lot of fun. Finally, we clipped, we saved all the vessels, we confirmed by ICG. Patient is right now stable, but we don't know because the brain was like stone even after 100 ml of ventricular drainage. Cysternal drainage was not possible because the aneurysm itself was in the interoptic space. So we will show you these videos sometime. It's crazy, crazy, crazy. But everything is okay now.
Very good. Okay, I'm ready to start.
Yes. Hi, Chizia. We are in the Neurosurgery TV. You can come in, Chizia. I'm talking in Neurosurgery TV. Okay.
Okay, you ready, Ipe?
Right.
Okay.
So we can start.
Yeah, okay. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami. This is Dr. John Bennett. We have another Neurosurgical Super Sunday with Ipe Cherian presenting on cisternostomy. And I'll first introduce members of the panel before we turn it over to Ipe. Hello, Andrea.
Hello, everyone.
Could you
Yeah.
say a few words about where you're at and who you are, Andrea?
Yes, I'm Andrea Gerosi in Italy, and I say hello to everyone. I've been with Dr. Cherian for the 3 months last year, a few weeks ago, and hello, everyone.
Okay, welcome, Andrea. Shuga, welcome.
Hi, John. My name is Sugar Hinojosa. I'm a neurosurgeon from Peru. I also have been with Professor Chirian like about 1 year ago for 4 months. My main interest is in trauma, and I found cisternostomy really, really interesting procedure and really outstanding in this new era of neurosurgery.
Okay, welcome,
Hi,
Shuga.
everyone.
Ipe, can we meet the residents behind you, please?
So we have Mohammed here from Egypt. He's a surgeon, and we have Jocelyn and Edmundo. They are both neurosurgeons. Jocelyn is from Mexico, and Edmundo is from Peru. So, in fact,
Okay, very good, Ipe. It's all yours. Take it away.
now, good evening, everybody. We are on to Neurosurgical Super Sunday today. Do you know, I was actually talking to the president of the World Federation today, and he's a good man. He's made a lot of changes, in fact. But you know, Western perspective is that the rest of the world should get funds for publishing and research. We're talking about neurosurgery. So if we get funds for publishing and research, it's better. This is what the West thinks. Now, let me give you a small example. 5/6 of the world, we do not have gamma knife. We do not have, most of the places do not have microscopes. Most of the places do not have coiling. It's good surgical technique. The only thing that can be done good in this country is surgical technique. If you don't promote surgical technique in these countries, and if you promote only research and paper writing in these countries, we'll have a, sorry to say, but we will have a complete set of surgically incompetent guys in these countries where they cannot afford it. Well, in the United States, you have an incompetent surgeon doing a tumor, skull-based tumor, you can gamma knife it. You can radiate it. If you have an incompetent surgeon who's not able to do an aneurysm, they can go for coiling. If you have an incompetent guy doing trauma, you can put them in the ICU with cooling and whatever, not multimodality monitoring and whatever Hutchison or rest of the guys say. In these countries, this is something that all of us has to realize. So the Western perspective that they're doing a favor by giving neurosurgeons a grant for writing something or publishing something is actually working against these countries. What they need to do, what the WFNS needs to do, is to establish cadaver labs and teach these guys how to operate. Africa, Latin America, India, China, Nepal, everywhere. Don't put emphasis on research, please. Put emphasis on microsurgical techniques. Otherwise, believe me, they have spoiled a generation. We have a lot of guys, senior and semi-senior guys, who believes in writing articles and not really training surgeons in clipping or in microsurgical technique. This is wrong. This doesn't work for us. So that is why today I'm not at war with anybody, as I had told my friend, a very good friend, Franco. I mean, Franco supported us a lot for sure, but his perspective, Hutchison's perspective, all needs to change because, you know, they are affecting our younger generation to think that research is important, more important than surgery. Only when surgery is done, you can do research on surgery. If you're not doing good surgery, how on earth can you do good research on this surgery? Finally, we will end up doing research and publishing papers on techniques of skin incision and things like that, or even maybe injections, because that is all we will be doing finally. So this is what I want you to change. I want the 5/6 of the world to realize that you need to be good surgeons first, and then you publish. Believe me, if you have taken up neurosurgery, if you are not publishing, you're still a neurosurgeon. But if you are not operating, you're not a neurosurgeon. This is the most important thing. Otherwise, go into neurostatistics, go into neuro data collection, or anything what you want. If you are a neurosurgeon, first learn your surgery program. Because that is what classifies you as a neurosurgeon. And that's very important. If you think publishing is important, it is not. It is not important in the phase of not learning good neurosurgery. So all of you, whether you're from Africa, Latin America, India, China, Russia, anywhere, go to labs, learn surgical techniques, and after that, go to masters, see surgeries. You know what you see as surgeries in conferences are edited 2-minute, 3-minute videos where everybody presents their best cases and you don't understand what it is like. So first you have to go to the cadaver lab. You need to understand the anatomy. You need to understand the 3-dimensional anatomy. And after that, you need to go to the masters to learn what surgery is like, what are complications, how do you handle them, what is the success rate. In conferences, you will never understand. In conferences, we show beautiful edited videos of 2 minutes. So go there and then you are ready to do surgery. Do surgery for 10 years. Be a semi-master at least. And then you think about publishing. Don't start publishing the moment you get out. You think that, oh, I have 5 papers, I have 10 papers. This is not good. This is what the world is coming to. And I believe this is wrong, and the WFN has to change this. All over the world, people has to change this policy of putting priority research over surgery. So starting with that, I'm going to give you a presentation which I gave 6 years back. Nothing has changed, you know. Nothing has really changed. And this 6 years back, what we did, I will present today. Most of the boys here, they have seen cystonostomy. They have done cystonostomy. They have first-hand experience in cystonostomy. It's microsurgical technique, and it's definitely advantageous over gross surgical technique. That it is common sense. You don't really ask evidence for it. I can tell you, when DHC was accepted as a norm, how many papers were there to support it? Even today, after 130 years, there are not many papers to support it. So how can we say that that is gold standard? To be gold standard, it has to be proven. How many times DHC has been proven? So why hold on to a surgery which has no roots in itself, which is based on a wrong statement, which is not microsurgical, which only gets patients to be robbed of their dignity? I say in a harsh language, we could say you're converting a cemetery to a vegetable market. That is what you are doing. So, except that you're not doing anything good. Everybody is proven that. Now you say there is a little bit of advantage here, there's a little bit of advantage there, but we've all done enough decompressive hemicraniectomies to understand that it doesn't really have an advantage, especially in severe head trauma patients. You can talk about a subdural, you did a DHC, and then the patient improved. Well, I have seen these kind of cases many times. We put the bone flap back in these kind of cases. You don't need a DHC for these kind of cases to start with. But when malignant brain swelling happens, I can show you a few cases, and then you will understand that what we are talking about. Okay, today, let's start off by saying what Machiavelli, Italian. Are you there, Andrea? Niccolo Machiavelli, he talks in his Prince, in his very, very famous or infamous book, The Prince. So there is nothing more difficult and dangerous or more doubtful of success than an attempt to introduce a new order of things. It is true even after so many years. It is true. You want to start something new? It's always the most dangerous thing on earth to do. Right. Now, why cystonostomy? And why not decompressive? First, we will talk about why not decompressive. You know, what is decompressive hemicraniectomy? It is the removal of portion of a skull to create more space to the swollen brain and relieve intracranial pressure. First described by Coker in 1901, although it was done before that. Now, what Coker said precisely is this. He put a needle into the lumbar area. He did a lumbar puncture. Although Coker started ventricular, Coker's point is there, but you know, he used to do these decompressives based on lumbar puncture measurement of ICP. So they did a lumbar puncture, and they found out that CSF pressure was not elevated. So that is when he said, if there is no CSF pressure, but brain pressure exists, then pressure relief must be achieved by opening the skull. The first part of this sentence is wrong. The second part of this sentence is also wrong. But for Theodore Cocker, that time, it was common sense. He thought the CSF pressure is not elevated. Why don't we open the skull and relieve the pressure? But imagine if Cocker had figured that the CSF pressure is high. Instead of this, if he had put in a cisternal catheter, then Cocker would have said, there is CSF pressure, and because of that, CSF is going into the brain, creating pressure. Let us open the cisterns. That's what probably Cocker would have said. This is because he did an LP and figured that there's no CSF pressure. These are his words. So cystonostomy, my friends, is based on a wrong conclusion, on a wrong statement, starts off with a wrong statement. And you guys have followed it like a tradition for 120 years without having any real evidence. And all of us knows what the results are. Yet, in the developing countries where it is mostly hit, when there is a new surgical technique which has come up for 10 years, which follows microsurgical principles, and many people have told about its results, you're still asking for evidence. You're still asking, where is the evidence? And when you want to publish something, if there is an evidence, you want to publish some things, the journals will not allow you to publish because, well, there are a lot of vested interests. The companies who sponsor bond cement, titanium plate, ICP monitors, these are the companies which endorse many journals. I've never said it out aloud, but this is the truth. Everybody knows it. It is not a secret. Everybody knows it. Most of the bigger conferences are endorsed by these companies. And for the neurosurgeons, it's a good thing because as a senior neurosurgeon, you don't have to go in the night, do some trauma because your resident who doesn't know much can manage the decompressive hemicraniectomy. Any idiot can manage a decompressive hemicraniectomy, by the way. He can manage the decompressive hemicraniectomy. He can talk big stories about malignant brain fungus or brain swelling and all that. And then he's going to close and he's going to come. You can collect this data in the morning and present in some conferences, which is endorsed by all these companies, which gives you ICP monitor, which gives you bond cement, which gives you titanium mesh. It's easy. It's an easy life. Think about these patients, please. If it was somebody you knew, would you really do it after knowing that microsurgery would have helped this patient? Even 10%, 20%, and we are not talking about 10 or 20%. The people who have been with me has seen these cystonostomy patients. So I'm going to show you some cases as well. Now, I'm going to tell you again about CSF shift edema and the Monroe-Kelly doctrine. Monroe-Kelly doctrine says that CSF, blood, brain are three things in the compartment. And Monroe-Kelly doctrine is wrong because CSF and brain interacts. It's been proven many times over. CSF gets into the brain for cooling and cleaning through Virchow-Robin spaces. If you guys have not read the recent papers, read Clarica's papers, read Nedegard's papers, read our papers. Okay, there is basic science research, very good evidence that CSF enters the brain through Virchow-Robin spaces. Okay, so Monroe-Kelly doctrine is wrong because CSF and CSF and brain communicates. So therefore, CSF can get into the brain. And or how on earth do you think the cisterns are not seen after a trauma, 2 hours after a trauma, you don't see the cisterns at all. And when I ask a neurosurgeons, group of neurosurgeons, they tell me they got compressed. It's impossible. Believe me, if you know hydraulics, it's impossible. You cannot compress 100 ml of fluid. The brain is swollen, cisterns are not seen. A child will tell you that the CSF went into the brain. About 100 ml of CSF went into the brain. And when you do a decompressive hemicraniectomy, what you're doing is, you're actually, it is a 12 into 10 centimeter, 12 into 10 centimeter defect. You are allowing 1 centimeter or 1.5 centimeter of brain to herniate into that defect. That is what you're doing by doing a decompressive. Whatever CSF went into the brain, you're allowing that brain to herniate out into the defect, causing axonal stretch, severe damage, and severe brain matter loss. So this is not something that you should be doing in developed countries, also in developing countries. This is a common sight. These patients, they call these surgeries about technical advancements in decompressive hemicraniectomy. I'm telling you, I'm being harsh. They might as well say about technical advancements in murder. So I don't think you can talk about technical advancements in decompressive hemicraniectomy. The damn surgery is wrong. Now, if DC decreases ICP, why are outcomes no better? They are no better because ischemic changes have already occurred, associated primary diffuse axonal injury, axonal stretch caused by shifting the brain bulk. Paradoxically, the release of pressure may accentuate development of brain edema and hinder recovery. Okay, this is not my sentences. These are all from studies. Okay. Now, let's not go into all that. This all has been discussed so much in detail. I'm going to tell you about what cystonostomy does. Again, I've been telling about this for 10 years. So, there is cisternal subarachnoid hemorrhage in trauma. This is common. Cisternal subarachnoid hemorrhage in trauma. The cisternal pressure goes up to almost 50. Through the Virchow-Robin spaces, CSF discharges into the brain. And that is what cystonostomy does. You put a drain there and let out. And so these are type 1 VR spaces. Type 2 and 3 VR spaces, Virchow-Robin spaces. Trauma, this is what happens. CSF gets in, brain is edematous. That is what DHC does for you. That is what cystonostomy does. Well, the G lymphatic pathway and all these pathways and evidences have been told so many times. Okay, let's get into scans now. Well, this is the scan where the GCS 4/15, both pupils dilated. Okay, 2012, beginning, we were starting our cystonostomy. We were doing cystonostomies with decompressives many times, and then we started putting a thin bone flap. We started doing a large temporal decompression, and then we started putting a small flap. You can see that flap there. But before that, let me show you things. Okay, see this scan. This is 4/15, both pupils dilated. Okay, there are no cisternal spaces at all. Brain is almost black. Okay. Now there's multiple contusions. What we've gone and done is we have opened, you can see that thin plate of bone there. This is muscle. That is the brain boundary. That is the brain boundary. We didn't take the cisterns, we just opened them. Okay, we didn't take any contusions, we just opened the cisterns. You can see the open cisterns here clearly. Now you see this kind of a damage. You remember this guy's name now. I'm going to show you this guy before he even leaves the ICU. Okay, his name is Sanjeev Preti.
नाम क्या है? हाँ? पूरा नाम क्या है? बोलो. संजीव प्रेती.
You can see that the sutures are still there. That means it's before 7 days. Okay, imagine a CT scan. Imagine the CT scan and see the result. With decompressive hemicraniectomy, this guy would have been in coma probably for 6 months, and after that he would have been vegetable. See this one. Okay, again you would do a decompressive hemicraniectomy. Here the brain is going to herniate because you see the CP angle cistern is widened. It's near herniation. There are many who would tell me I would just remove the contusions on both sides and leave it, but see the edema. See the edema. Many would say, okay, I would do a decompressive hemicraniectomy on the left side. Okay. See what we did? We kept the bone flap back. There was a small extradural hematoma. He came walking 8 weeks later. We didn't take out even the contusions. There is a contusion here. Took out these contusions which came out. The main thing is cisterns are open. Okay. There's a small extradural hematoma which would never have been there if the pressures were high. So, right. Let's see some more. So, this is a patient with a classical subarachnoid, traumatic subarachnoid bleed. And then when it was severe, this is 14/15. And then he deteriorated to 4/15 with the right pupil dilatation. So we went ahead and took this out. Severe brain swelling was there, but subarachnoid. So just like an aneurysm, we took out all the, we opened all the cisterns, and after opening the cisterns, brain was lax, we kept this back. This was 14/15 at discharge. Residual right third no palsy was there, which improved in 6 weeks. 15/15 in 6 weeks. Another patient, GCS 4/15, right side pupil dilated. In fact, when he was brought to the emergency, his GCS was much better, but he deteriorated to 4/15, and we were called in immediately. We thought this was the initial scan, but you see, immediately after the procedure, you see the damage. And here the brain was so swollen, so we put in the catheter here, and you can see the damage here. And with this damage, we will show you when he's getting discharged, we will show you what happened. This is when he was getting discharged. At discharge, next one. You see, CP angle cistern is not only widened, herniation is already started. You can see the herniation starting. The midline is, if you allow some more time, this midline will go out of this skull. You see the midline shift? That is the midline shift. So I'm sure many of you would have agreed for a decompressive hemicraniectomy here. I cannot think of anybody who will not. See the edema? So what we did, We did a cystonostomy, kept the bone flap back, and took out that contusions. Edema is still there. This is the guy. He's not even discharged from that ICU. He's still with the cap on. He's probably in the ward. Okay. Right. Next, presenting GCS 7 with anisocoria. So you can see the extensive damage. Discharge GCS 15. Okay. Now, okay. Another one. 6/15 left pupil dilated. No cisterns at all. Absolutely no cisterns. Okay. Really, really severe brain edema. So severe brain swelling, tentorial herniation noted with contused third nerve, cystonostomy done, brain lax and pulsatile. Okay. Right. Many of the boys here has seen even minimally invasive cystonostomies where we have gone in with just 5 centimeters. And then after once you reach, it's a difficult task to get into the cisterns, but once you get into the cisterns, release that CSF, brain is pulsatile and lax. Okay. Only case when we don't get that is ischemic brain. Okay, another case, GCS 40/15, both pupils dilated before surgery. Okay, you see this brain. The brainstem is almost elongated. It's black. The brain is black. Okay, 40/15, both pupils dilated. Young woman. Okay, very young woman. What would you do? Bilateral decompressives? Gelberg, topectomy. We just did a cystonostomy. You can see how much retraction I had to make. You can see how much retraction I had to make. And after this retraction, you see how this brain is. You can see the cisternal catheter, which is actually not placed properly. But the brain is lax. After the cystonostomy, the brain is lax. This is the retraction injury. People tell me, oh, do you have retraction injury? Yes, we have retraction injury. But see her on the 7th postoperative day. Okay. She still has that is her on. See this brain. See the brain stem. Okay. And you see the post-op scan. We've taken out the PF positive as a hematoma. And after that, we did a cystonostomy, and this is the guy. This was all done 6 years back. Now see this case. I'm not telling you these kind of cases should be operated and you'll have fantastic results. No. 4/15, both pupils dilated. So brought to the hospital within 3 hours of trauma. See the brainstem. Okay. What would you do in this case? Bilateral decompressive. See the damage on this side. See the damage on this side. What choice do you have? ICP measurement. Okay. If you put in an ICP catheter, I'm sure brain will come out through that. You probably, have brain in your ICP catheter. You know what I'm talking about. Okay. So we went ahead, did a cystonostomy. And this is immediately after the cystonostomy. Brain is lax and pulsatile. I'm not saying the brain, it is magic so that we cleared everything. No. Okay. No. I'm saying the brain is pulsatile and lax. Okay. That's what I'm saying. That's what this surgery can do. All right. This is a discharge, the same guy. See him. Now, operative technique. You must understand that I did a mistake when I started off with operative techniques, which are very, very tough. I talked about unlocking the brain because I was a skull-based guy. And I talked about opening axial unlocking, sagittal unlocking, all those nonsensical things. I was wrong. Okay, I would accept that. And it scared away all the neurosurgeons who even wanted to try it. So for many years, I was alone till three guys, Wang, Roy, and Parthiban took it up. They came and told me, see, listen, you can talk about cystonostomy, but it's very simple. So there was this guy from Iran also, he published sometime, and he said you didn't have to do anterior clinoidectomy, posterior clinoidectomy, or anything like that. Opening membrane of reliquis is important. But once you go through the initial storm, get into the cisterns, open the cisterns, wash out the blood. It's a rather easy thing to open the next things, open the next cisterns, put in a drain, come out. Help you a long way towards your microsurgical training. Instead of doing a decompressive hemicraniectomy, having the brain come out like toothpaste, trying to close, somehow standing on the head, trying to close it, and then have a semi-dead patient next day morning. So operative technique, well, it's much simpler than what I described it the first time. Okay. Let's see a few. So this is a frontotemporal craniotomy with severe brain swelling. See the brain coming out. As soon as you open, the brain is coming out. That is after the surgery. See how lax it is. You see the damage, but how lax it is. It's not coming out of the brain, coming out just like before. Well, we've talked a lot about posterior clinoidectomy. Let's not go there. Let's not go into skull base techniques and all that. Do a simple, proper, simple pterional craniotomy. Take your sphenoid ridge out. Open, go subfrontal over the orbital roof. Okay. Removing PCP again. Don't even see it. Okay. See it if you are basilar quad. This is something that you will see. That is a contralateral third nerve. Okay. This is a video 6 years back. So that's a basilar quad. Very useful for basilar aneurysms and things if you are planning to go that way. Well, if you're planning to publish, this is suprabrow technique. Please don't ever think about it. Okay. Don't even think about it. So, well, the complications of cystonostomy is something that we must discuss. Of course, it's not an easy surgery. So definitely there are complications. So the thing is to get experience, and to get experience, you must do something. You will not get experience by talking or publishing. Okay. To get experience, you have to watch first, and then you have to do it. Otherwise, you're not getting experienced. So go ahead, as young neurosurgeons, get out of your comfort zone. Don't listen to the West saying that you must get funding for research. No, as long as you're neurosurgeons, first justify that name, that you're a neurosurgeon. So go to the cadaver lab, learn. After that, when you're competent, start publishing. Okay, I'm not saying don't publish, but moment you finish, you start having papers, there's something wrong with the system. You end up as publishers, neuro-publishers, and not neurosurgeons. Okay, so don't do that. Well, there are some lessons that we learned. Final bottom line is this is not a panacea. This is not something that'll cure everything in the world. No, we learned that. But it's definitely way, way better than, I would add way, way, way better than decompressive hemicraniectomy. Okay. So we have papers. No, these are the initial papers. Now we have chapters. If you type in World Neurosurgery, you will have enough. Acta Neurochirurgica just published another paper with a scathing review from Franco and Hutchison. Okay. Well, about Franco, he's been of help. Hutchison, I can only say he collects data. He collects very good data and publishes very good stuff. Whatever is done by his residents, he collects in the morning and publishes that in a nice way with good English, and also goes and presents it in large conferences. I really don't understand why this is something great. Okay. I don't know why he should even be called a neurosurgeon, with all due respect. He should start operating. If he is a neurosurgeon, he should start operating. Okay. This is my challenge to him. This is what I have to tell him. If he can write all these scathing reviews, but he will not be able to stop progress. He will not be able to stop what we are doing. And he doesn't have the perspective of developing countries, our countries, where what we need to do is we don't try to ape the West by getting gamma knives in every villages, getting coiling in each villages, getting multimodality monitoring in each village. It's impossible. Try to learn surgery. Go to cadaver labs. Every medical colleges have cadavers. Go learn. And after that, be with some masters, start surgery. This is what you should do instead of aping the West. So thank you very much.
Okay, very good. Thank you very much. Okay, any comments or maybe we can meet the new arrivals. Dr. Manbachen, could you introduce yourself to IPE, please? Are you there, doctor? Let me see if I can get him. Did you need to unmute there? There you go. Oh, possibly can't get through. Dr. Cabullo, could you say hi to IPE?
Hello, Professor Hype. My name is Kabulo. Yes. How are you, Prof?
You're from Tanzania?
I'm from Congo, but I'm in Zimbabwe, training in Zimbabwe. Yeah. I have two questions, Prof.
Yes.
Hello?
Yes, we can hear you.
Yes. Yes, I was saying, is there a timing for surgery for cystinostomy? Because all patients are not coming at the same moment when you are receiving them at the hospital. That's one. And the second one, it's in case you get bilateral acute subdural hematoma and you want to do cystinostomy, how do you proceed? Do you start with the hematomas or you do one side and cystinostomy? Thank you.
Okay. Good questions, both excellent questions. Now, you know, in our part of the world, we have helicopters bringing in patients or ambulances bringing in patients very fast. So we have a problem. So patients can come very delayed. The only thing you have is when you should not do cystonostomy. One thing is if the motor score is 2 or less and the brain shows signs of ischemia, this is not a good time to do cystonostomy. Maybe you should stick to decompressive. Okay, because there is ischemia. But if the brain is not showing ischemia, if the motor score is, at least 3, then it is very good. This is a good time. So don't wait. Don't put in an ICP monitor and cook that patient on a slow fire. Okay, go do the surgery first. If you think that this patient needs surgery, don't have any doubts. Don't put in the ICP and say that it is 27 now, tomorrow I will wait, and by the time it is 40, you want to do a decompressive, everything is over. So do proactive surgery. So to answer to your first question is, there is no time, only time when not to do cystonostomy, I can tell you. Okay. Otherwise, any patients come to you, do it. Okay. If it is indicated, of course, you don't catch somebody off the street and then do a cystonostomy for them. Obviously not. So you have to have indications for this. If you have indications that these patients need cystonostomy, of course, you do it. Second answer. The second question was, what was the question?
Bilateral. In case you have bilateral, yes.
Subdural needs to be evacuated for sure. Okay. So I start off with the thicker subdural. Wherever is the thicker subdural, I evacuate it, do the cystonostomy, and then go to the other side. Once I make the cystonostomy, the brain is going to be lax. I go to the other side, I evacuate the subdural. If there is a subdural, I evacuate. If it's very, very thin, I don't. But if it's a reasonable subdural, I will evacuate it, but I don't need to do a cystonostomy. And also, I'll be, after the cystonostomy on one side, I'll be able to easily put the bone flap on the other side.
Yes, Prof. Are you not fearing the brain to expand, the other hematoma to expand when you are draining the thickest one? The moment you are doing the cystonostomy, the brain will relax. The other one won't expand, the small one.
Don't think too theoretically. Okay, we are surgeons. Okay.
Whoop, okay. Don't know what that is.
Extradural anterior dorsal technique.
I don't know. Someone, I think that's on your computer, right?
In this case,
Okay. So did you see that? Okay, now let's go back. How do we go back? No, it's not sharing. It's, can you hear me?
Yes.
Okay, I just put it in the center. That is all right. So don't think too theoretically. Okay, when you do the cystonostomy, the brain immediately turn on the other side. Don't worry too much and then just do it. Okay. It's whether the brain will expand. If it expands, you go fast and take it out. Okay, take the subdural out. Don't think too much, you know. Do you know about the story that three doctors went for hunting the ducks, you know, and one was a psychiatrist, one was a pathologist, the other was a surgeon. So they went to hunt the ducks, and the psychiatrist said, I think I see a duck, a partridge, but maybe it's my delusion, you know, or maybe it is a hallucination. So the pathologist, he said, it could be, you know, a partridge, it could be a parrot, it could be something else. So the surgeon took the gun, shot it, and said, okay, let's see what it is. All right, I think it's a duck. So that is what a surgeon is. They don't really wait, and that really, really signifies a surgeon. With all these research and everything, we have literally screwed with our brain. Okay, you must know, you must be able to focus on to one thing and hold on and latch on to it, and then go do it. This is what we are for. We do not sit and analyze. There are many people who will sit and analyze. You know, today I saw a surface lesion, completely surface lesion, and they are sitting and analyzing what it is. I said, take it out, and then you will know what it is. Okay, so Kabulo, my answer to you, I want you to start when I want you to come here. Okay, like your friend Gracian Guenero, who came here.
Yes, Prof. Yes.
I want you to come here. I want you to see cystonostomy firsthand. Okay, stay with us,
Yes,
like boys. Stay with us. See cystonostomy, see aneurysm surgery, see skull-based tumors. Okay, learn. Come to the cadaver lab. Do enough cadaver dissections so that you have some confidence about doing things. Take the exam, then go back with flying colors. Start doing good surgery in your place. After 10 years, you think about research, my dear boy. Don't think about it before that, okay?
Thank you so much, my professor.
Okay.
Right. Any other questions?
Sugar, you have any comments that you would like to give? I mean,
I think one point that Professor Chiria make really clear is the necessity of improve our skills. The problem with cystonostomy is that it's challenging to do it. I mean, it's not everybody can do it. You need to develop some skills. And that sometimes, especially for senior neurosurgeons that don't have this much practice, is difficult to understand. We talked with Professor Servadei in China about the necessity to improve neurotrauma. And I think the concept of included microsurgical technique and skill-based techniques to trauma is good. We have seen the results. With one really important point that Hira also told us yesterday is the necessity in this era of um, evidence-based medicine. We need to collect our data and put it together so they can. That way we can prove. That way we can prove that this is working. It's difficult for not everybody can go to Nepal and see how is all this been done and how magnificent it is in the surgery itself. But for us that we have been there, it's a challenge to start to do it in our countries and put the effort together and collect our data in systematic way so we can prove other guys, especially we, you know who, that we are right and they are wrong.
One thing, Sugar, I will tell you something, when Jesus Christ entered Jerusalem, made a statement saying that, if these people don't hurrah for me, the stones will hurrah. You understand me? I'm telling you, 10 years they asked me for evidence. 10 years they told me, do these trials, that trials. I never listened to them. Today we are not alone. We have a huge group of people who believes in us. Because we don't do anything, we do things for the greater good. We don't do anything to glorify myself or glorify somebody else. We do things for the greater good of people, the greater good of society. We are not companies with vested interests. We are not with big journals who will look for p-values and that values. Let me ask you one single thing. How many papers did a neurosurgical drill have before it was validated? How many papers did the CUSA have? How many papers did the microscope have before it was validated for surgery? How many papers did decompressive have before it was validated? So-called validated. Neurosurgery developed in the era of no evidence because we don't lie and we have common sense. Let them not influence you by saying that you need evidence for everything. You don't need evidence. Okay? It is a wrong statement to say that let Hutchison jump out of an airplane and say that, I will say that with parachute, I will say that, okay, let us do a study. I think without parachute, he will survive. And he can say only with parachute, he will survive. Let us make a study like this. Do you need evidence for this? You don't need evidence for this. Why do you need evidence for something so obvious? 100 years old surgery versus microsurgery. Do you think you need evidence? Experts doing surgery versus residents doing surgery. Do you need evidence? Improvement of surgical skills versus going back in surgical skills. You need evidence? It is so bloody obvious, I'm sorry. But yet, they want to hold on as much as they can. And we have been influenced in a way. It's like a Barbie doll. If a child, it's so influenced by Barbie, if you give a toilet named Barbie, she will take it. I'm telling you, it is branding, it is in your brain, that evidence. Most of neurosurgery's advancements were in the era with no evidence, where people were good surgeons. British neurosurgery is finished because of evidence now. There's no more, I can see a few good people who really doesn't care about evidence and does good surgery. But otherwise, rest of the guys are just evidencers, p-valuers, publishers, collectors, data collectors. Don't get into this trap of evidence. I am being sentimental or emotional, but believe me, this is a trap these guys have set up in the last 50 years. They started giving funding for research to neurosurgeons. Don't take this funding for research. It's nonsense. Learn neurosurgery, believe me. Learn neurosurgery. If you want funding for research, go for something else. Not for neurosurgery. You finish your residency and then you start a research. What nonsense is that? You have to learn how to operate, and it will take you 10 years. So, with all due respect for research, do research after you are a semi-master. Never before that. Okay? And when people ask for evidence, laugh at them, not on their face, but laugh in your heart. Tell them, remember, the stones will hurrah. Okay? If they don't, the stones will hurrah. I'm telling you. Each young neurosurgeon who comes out, you will be able to tell them it is correct. And when something is correct, you cannot stop it. It's like trying to stop a lightning strike. This is what I told Franco. It's like trying to stop a lightning strike. Can you stop a lightning strike? If you try to stop a lightning strike, you'll be burnt. All you will hear is a sound. Okay? That is what will happen to people who will try to stop progress in neurosurgery. Okay? They have stopped it for 50 years. We have a generation of neurosurgeons who doesn't know how to research, who doesn't know how to operate. Frankly, I'm telling you, 5, 6 of these neurosurgeons are in developing countries. They read papers and they get orgasms reading papers and p-values, but they don't know how to operate. Most of them, they don't use microsurgical techniques. They don't teach anything to their juniors. This is what is happening. Get out of it. Go to cadaver labs. Learn. Be with masters. Be with people who are willing to teach you. Okay? Let them waste away. Those are the guys. They're now. Okay? We should give them a good funeral party. Bye-bye. This is what is needed now. So, we are neurosurgeons. We're supposed to have real balls in handling things, real balls for every other thing. We're radical people. We are probably psychopaths. And that's why we took up neurosurgery. It's not easy to clip an aneurysm and then go on and do an AVM and then do a skull-based tumor where the results are not so good. It was 100% mortality before. These people were psychopaths. Survived that. That is why neurosurgery improved. We're not here to sit on a cushion of papers and some academic positions and some companies supporting us doing bloody surface meningiomas and writing papers. No. So, when somebody asks for evidence, no evidence. Okay. Still now. When these guys try to get me to their side by telling me, okay, you should have a randomized control trial, I say, thank you, honey. Thank you, sweet guy. No, I don't need evidence. I've been doing this stuff for 10 years, and I'll do it for another 10 or another 10 or another 10. And then there'll be people to follow. There's no question about that. Remember, the stones will hurrah. If people say I'm mad, let it be so, because I would like to go that way. Okay? But I'm sure after one more generation, people will realize that microsurgery is very important for neurosurgeons. Not some ICU multimodality monitoring and p-value and all that nonsense. Okay? Remember that, please.
Sorry, Prof.
Okay, very good. Very good.
I have one more question.
Go ahead.
Yes. Prof, I'm going back to cystinostomy. I saw most of your cases, once you are done with the cystinostomy, the brain is relaxed, very relaxed. So do you usually replace the bone, or in some cases you don't replace the bone, you do a craniectomy?
Yes, I always replace the bone. Most of the time we replace the bone. My boys also, consultants also replace the bone, except when we have any doubt whether the brain is relaxed, relaxed or not. If the brain is not relaxed, then even after cystinostomy, we do not keep the bone flat back. Because cystonostomy is not to prove a point to anybody. We're not saying that we can always put the bone flap back. No. If the brain is not relaxed after cystonostomy, there's no need to put the bone flap back. So in these times, we don't put the bone flap back. That is very rare these days. Now all my consultants are doing it. So it's pretty rare for us to see that the brain should, the bone flap cannot be put back. But some of these cases are out of inexperience also. So, of course, when I started learning, I had a huge learning curve. And now these boys, the consultants that we have here and the fellows we have here, their learning curve is much smoother because I have made all the mistakes. And I can tell you what mistakes I made and you can learn from it.
Thank you, Prof.
Welcome. Dr. Manbachan Singh, do you have any questions? Are you there? I don't think he's here. Okay, right. Yes, John? John, you're muted.
Dr. John, you are muted.
I'm sorry. I guess I'm going to fire that director. Okay, I thank you very much. And we'll continue this next. And thanks all the guests for coming. Okay, we're going to stop the recording. Okay, we're off the air. You guys can just chat.
Today I was, after, Roy and Lorenzo had a beautiful paper published in Acta Neurosurgery, and I saw this stupid review by Hutchison, and I talked to Franco and I made things very clear with him, but I did not like the way these guys wrote a review. They've been trying to, by hook or crook, they've been trying to put this down, and us to publish in big journals, because all these journals are manned by their minions, and these companies which are providing, who are manufacturing titanium meshes and bond cements, especially Johnson & Johnson. I'm sorry to name it, you're off the air now, but they are the guys, who are paying. You just see the paper. At the end of the paper,
yeah, say that they sponsor Professor Cervedei, Integra and Johnson. That's right. I mean, even here, a lot of my consultants do the compressive,
so
only
Johnson,
to make a second surgery.
millions of dollars. Franco is a good man, believe me. Franco is a good man. I know him. Okay, we are off there, but Franco is a good man. But it's not easy for him to change the system. As long as just like this Hutchison and these guys are, they're placed in Cambridge and they think they can do anything. So I'm proving it to them they cannot. I'm giving a reply right in their face from Nepal. And earlier they used to ignore, they used to think, they used to act as if there is nothing called cystonostomy. They cannot do that anymore. Because the whole of China, many places in India have taken it. And they're getting good results. Now it's going to South America, it's going to Africa. How long can they shut up? So now they're trying to trivialize it. This is the next line. And saying that we need evidence. We don't need any bloody evidence. They need evidence. We don't need it. Okay, let them bring evidence for decompressive is better than cystonostomy. Then we will talk about it. These guys, some of these guys are, they've gone too far to see what is the truth. They've gone too far so that they will sink with that. There's no question about it. Okay? The other guys, the younger guys can still, I'm not saying join our side, join the truth side. Join the side of the truth, not with the companies. We neurosurgeons, we are psychopaths, but the only thing we want, our patients better be, otherwise we cannot be even classified as physicians. We have to try our very, very best to save that patient or to stop a deficit or to be, whatever you do, you're not gods. None of us are gods. We have to try our very, very level best. Whatever happens to us, we have to try our level best to give our best to the single patient that we see or we operate or for. We have to try it. We cannot collude with companies. We cannot collude with, others who gives us benefit. We cannot be doing a mafioso with journals, publishing whatever is, good for you and whatever contradicts you. No, this is not correct. So this is why I have come out, with the scathing remarks in that group. So that people understand. People can think whatever they want, that I am radical or whatever. But I have not done this for 5 years. I've been very, very decent. Okay. After 2015, Rome, maybe in 2017 or something in Naples, I was a bit naughty, but otherwise, I've been very, very nice. Not anymore. These guys, okay, I'm going to kick their ass. Okay, and we will see. But they will need a lot of things other than evidence to stop us. All right? See you.
So you things were better when you didn't need evidence, right, Ipe? In the old days, like in neurosurgery?
What evidence do we have for drills, microscopes, bipolars? All the good things in neurosurgery did not come with evidence. And after came John, neurosurgery is never advanced. Instead of that, what is advanced is industry. Gamma knife, $2 million. Coiling,
Yeah.
billions of dollars. Multimodality monitoring, ICP, titanium mesh, billions of dollars. Evidence is industry. Good old neurosurgery is dead because evidence came in.
Yeah.
With evidence, you can make a guy look like a girl. Statistics is exactly that. The most biggest liars are in statistics. You collude with them. You think I could not manufacture a paper saying cystonostomy is fantastic? You think I could not? I had a lot of guys approaching me and saying that, hey boss, just give your name, I'll make a paper for you. I said, no. For God's sakes, no, I will not do that. I will never do that. We have thousands of patients who we have done. We've not really collected evidence. We never had the time for that, time for sitting down because these guys don't operate. Now I have the time to sit down, but earlier, no. I didn't have the time to sit down. We were doing case after case after case. And we did not know how to, publish and all these questions, all these statements of publish or perish and all this bloody nonsense over the years, You should put paid to all this. Neurosurgeons, operate or perish. That should be the motto now. Not publish or perish. Effing nonsense. Okay? I'm somebody who never published. So never. I didn't have enough publications for my academic post. Believe me, my MCA student got academic post earlier than me because I did not publish. It's not because I couldn't publish. I was the executive editor for one of the major journals. I could have pushed any journals. I could have pushed any papers I wanted there. Believe me, that's what people do. I never did that. Never. Not one article of mine was published during my time as an executive editor. I was the guy approving those articles in AJNS. I did not do that. So we should speak the truth. We should improve our, our technical skills. We should be more kind, not to these guys, okay? And we should have balls. That is what defines a surgeon, all right? Do that, you'll be happy. If you don't, you'll always be publishing.
One question, Professor. You going to present something of cystonostomy now in ICRAN in India in August?
Yes. Of course, yes. I will go to also Delhi. I just talked to Deepu in AIMS, I'll be giving a lecture 20 minutes on the future of neurosurgery and about cystonostomy. In Iceland,
I'm going to India, to Ikran,
yes, I'll be
this
there.
year.
It's a pity that I could not go to Pakistan this year because to the Iceland,
Yeah.
very good friends there, or everybody was there. I missed it, but you know, with the present situation between India and Pakistan, visas are very difficult. Okay, that is why I could not go there. But otherwise, I would have been there. In India, definitely in Bangalore, I'll be there.
You know what? The future's more likely to be more evidence proof. It's probably not going to get any better, right? It's not going to go back to being less evidence proof. What do you think the future looks like?
No time that people have realized with the egg yolk and cholesterol, with coconut oil, with the heart disease and the egg, you know, a lot of scams. People are realizing that. Even major journals like Lancet's editors, if you ask them, what is this evidence-based study? It's all a scam. People have realized, okay? They're all saying it out. So I don't think evidence has any future. Evidence only will have a past, believe me. Well, industries will find a new way. I'm sure they will find a new way because they're smart. They'll find a new way. But this avenue is over. This avenue of evidence to push all their drugs onto you, push whatever they want to sell onto you, and have idiots to publish evidence for that is over. People are realizing it, you know. Patients are not idiots. They're killing doctors. They're doing things. They're realizing it. These things are coming out in the movies. It's not easy anymore. So if you want to push a product and you give some perks to a doctor and ask him to write your medicines, that time is over now. People are not idiots.
Okay, very good. Okay, gentlemen, thanks everybody for coming, and young lady in the back. I will see you next week. Thanks a lot, guys.
Bye, Professor.
Bye-bye.